I'm from, oops, sorry, I'm from India, and right now I am in New York City doing a bunch of observerships. I'll be applying for this year's match, and I really love soccer and clinical reasoning. Those are my two passions.
Love it. Okay. What's your
Great combination.
great combination? There are a lot of folks with that combination here too. What's your favorite soccer team?
Oh, I love FC Barcelona.
Oh, nice. Well, Barcelona is pretty great, I have to admit.
Yeah,
They're pretty freaking awesome. So great choice.
thanks.
All right. Can we get the board up? Oh yeah, absolutely, Mariana. I thought I made make. Oh, I think you're already a co-host, Mariana. There we go. All right. Akhilesh, do you want to get started?
Sure. So the first aliquot is, it's a 27-year-old male with a chest swelling.
Awesome. I'll get started on the first aliquot. And I also just wanted to say a huge shout out to Yaz and the case review committee who have worked so hard and just to make it accessible to everyone. And we're so happy to have you, Akhil. So thank you so much for bringing this case. Starting out, this isn't a lot of information. So it's a younger patient. So in a younger patient, I would want to know past medical history, if there is any, including any childhood history, vaccination history, any genetic disorders or anything like that that was relevant, as well as risk factors, including travel, sexual exposures, drug or toxin exposures, or other exposures. And then here, the chest swelling, it's a little bit non-specific. And so I'm going to want to get more information about this. I'm going to want to know, is this a localized lesion in the chest that appears swollen? And if so, does it appear to be on the chest wall or a nodular lesion deeper in the tissue? And if so, kind of how big is it? Is it ulcerated? What size? What is the appearance? And then, or is it more that the chest appears diffusely swollen, like there might be edema there, or there might be air trapped in the lungs, or some sort of abnormal curvature of the spinal cord or chest wall causing it, because that's going to inform my differential and help me move forward in this case and thinking about, could this be some sort of mass, whether it's infection, inflammatory, neoplasm, something congenital, or other lesion. Sharmin, what else do you have to add?
I'm just so impressed that you just, with calmness, started discussing chest swelling. I saw with the chest swelling, I'm like, I don't think I've ever thought about chest swelling. So I feel like you've got me already. But no, nothing to add. I think what you said made sense, like thinking about the location of the swelling. What does that actually mean, especially in the physical exam, to be able to build a better differential? So I'm excited to hear more, Akhilesh.
Okay, so I'll give you a bit more of the HPI. So the patient noticed the swelling on the left upper anterior chest wall a month ago, and it has grown in size since then. There was an episode of chest pain before the onset of swelling, which subsided after taking over-the-counter painkillers. The patient also reported an episode of night sweats about 1 week before presentation. There was no history of any fever, rash, weight loss, cough, joint pain, or loose stools. And the social and family history were non-contributory.
Thank you so much, Akhilesh. Can I just clarify? So is on both sides, like left upper and right upper, or just left upper? Sorry, I didn't catch that.
Left upper side.
Okay, left upper side.
Yep.
Great. Yeah, so in terms of, now we have a location in terms of the chest wall and where that swelling is. I don't know if I can make that much more progress than Anne Marie did. The things that, often when you're thinking about a problem that is like new to solve, I like to think about anatomical approach and also thinking about the company that a problem keeps. So they have a left upper swelling that started maybe with this episode of chest pain, whether the lesion itself is painful or that was unrelated is one question. And the other one is like night sweats. When I think about like night sweat, oftentimes I think like tuberculosis, infectious etiologies, like anything inflammatory that potentially could cause night sweat. And in someone who's 27 years old, two questions comes into mind. One, is this person's been in care? Is it someone that has been followed by primary care? Is this the first time they're presenting? Because oftentimes young people tend to be on the healthier side. And even if they have any medical condition, it might not come to surface until later on. So I really love that Anne Marie thought about the congenital issues that we may be seeing effect of it now, or is this something that has been brewing for a long time and this is a presentation of it? But if we assume this person has no other medical and this is new, the thing that takes priority is thinking that a bit night sweat, if that is an infectious lesion, common things being common, and I'm thinking a lot of the time like skin and soft tissue infections, if there was like a folliculitis or that causes an abscess, like I feel like that is one of the known misdiagnoses here, is a skin and soft tissue infection that is like presenting maybe as an edema. I think like getting a better sense of physical exam would be helpful to better narrow that. And Marie, any other thoughts from you?
Great summary. I guess I'm kind of wondering, is this an outside going in phenomenon or an inside going out phenomenon? So I'll be curious to see what the physical exam helps with that.
Oh, boom. That's fantastic. I love it. Go ahead, Akhilesh.
Okay, so I'll share the exam findings. So the vital signs of the patient were normal. And I'll jump to the local exam first, okay? There was an oval swelling measuring 6 by 5 by 2 centimeters, noted on the anterior chest wall, spanning from the left second sternocostal junction to the fifth left sternocostal junction. The surface of the swelling was smooth, and there was no erythema, no sinus formation, no ulcer or any discharge. There was no crepitus and no signs of any skin trauma. And the temperature over the swelling was normal. The swelling was soft and it can't be reduced. There's no tenderness to the swelling, but fluctuance was positive. There was no cough impulse, and the range of motion of upper extremity was not impaired with it. The rest of the physical exam was unremarkable.
So it sounds like that the lung exam is clear and we didn't feel any lymphadenopathy or anything else anywhere else.
Yeah.
Is that correct?
Yeah,
Okay.
that's correct. There was no lymph nodes.
So this is really interesting. It seems like it's a fairly large lesion by the description. It seems like you said 6 centimeters. Is that correct?
Yeah.
Okay. And it sounds like there's some fluctuance there, but it doesn't actually drain out to the skin. And so just thinking about base rate here, I'm thinking about an abscess first and foremost, an infection, just to like first think about, ground myself in base rate and say, like, what is the thing that I need to identify most quickly and like act on, and then what is most common? And for both of those, that would be my first thought, especially knowing from the HPI that there's been some sort of inflammatory signature of this. It is interesting that there is not a lot of redness over the site, and it doesn't seem like there's surrounding cellulitis. And so I'd want to see if I could further characterize this with imaging. One question I would be thinking of is, does this transverse through tissue planes? So is this something from the lungs coming out or in the subcutaneous tissue that is like also in the lungs. It doesn't seem, it could be from the outside going in if there's like a skin break or something causing a localized abscess there. And then I would also be like thinking about surrounding structures like the ribs, like the costochondral junctions, like could there be some sort of osteomyelitis, some sort of septic process there as well. And then in addition to like the common things like staph, like strep, that can cause abscesses, I'd also be thinking about actinomyces, tuberculosis, fungi, some other, because of the time course, more like indolent, slow growing processes. Nocardia would also be something I'd be thinking about. But then here, I'm not completely sure this is infection. And so I'm still thinking about like a malignancy, some sort of cyst, some sort of other process here. And so I still want to like keep and like a sweet syndrome, even though it doesn't seem as likely. So I still want to keep my differential broad. And Charmin, sorry, that was me just kind of rambling.
No,
what
that was
do you have to add
fantastic.
here?
No, that was really, really fantastic. I'm right there with you. I think, abscess is the one that we definitely want to rule out to make sure this is not an infection. It's been going on for a month. So at the same time, I think it's like, I think we can't miss. And at the same time, like a month is a long time to develop such a huge abscess without any like systemic signs of inflammation, I would think. So it seems like the vital signs were normal, like getting some more lab work to see if there's any like systemic involvement. Does he have increased white blood cell count? What are his other labs doing would be informative. And I think imaging is a good call, like even maybe starting with the ultrasound. To see, what inside of that mass looks like. Is there a lot of fluctuation? And then I loved your thought about like whether it transfers different planes. And I think something was very similar to Ann Marie. So infection being one of them. The other one, I think, malignancy. So thinking about skin, thinking about like liposarcomas, like arising from the muscles or bone, given like he's like younger, there's some of these malignancies that can be seen in the younger individuals as well. So I think that is I agreed about like getting more labs. Other one that I want to make sure, just to get HIV as well, to make sure that we establish like if the person is like immunocompetent, immunocompromised. That's another test that I would get at this point, plus our usual labs and thinking about imaging. All right, Akhilesh, I'm on the edge of my seat. Do you want to tell us some more?
Okay, so let's go to blood work and imaging, right? So we did blood work, which showed no abnormalities. The HIV test was negative. We got a chest X-ray done, which did not show any changes. We did a CT scan, which showed a midline cystic lesion in the subcutaneous tissue of the chest wall, just anterior to the sternum, with underlying bone was unremarkable, and the lungs, they were normal. There were no lymph nodes in mediastinum.
All right. So that is reassuring in terms of like a lab being normal. There's like no systemic involvement. However, I would say young folks have a lot of reserve, but at this moment, it seems like at least we don't have any systemic involvement. I would still, thinking about lymphomas, like liquid malignancies presenting in odd ways. The fact that there's no other lymphadenopathy is reassuring. I would still consider to thinking about like cytology and reviewing a smear in this patient to make sure we're not missing any abnormal cells. And then in terms of like the cystic lesion that we see, again, it's contained, which is good. I would love to know what that cyst is. So I think taking a sample is important. However, the knowledge that I have is like whatever it is, you don't want to also like risk spreading it, or is it something like safe to want it a needle and take a sample of it. Because, it doesn't, like a cystic lesion, the differential is broad. And I don't know how much more progress I need to make. I think one is like to make sure, cystic infectious lesions, we thinking about the exposures, some of like the parasitic infections. However, we're not seeing anything in the history that would help me make diagnostic progress, or there's gaps in my knowledge that I don't know how to make progress to. So I would love to take a sample of it if it's safe. Ann Marie, what are your thoughts?
Yeah, I'm not going to say I have a robust differential for a cystic lesion in the chest wall, but I'm definitely thinking about kind of still wondering about congenital things, even though it seemed kind of a late onset. Like, could this be some sort of like bronchogenic cyst or other thing that could be going on, or still like, is this some sort of connective tissue malignancy, but also thinking about infectious etiologies that could cause a cystic lesion considering how big it's grown. But yeah, I don't have a robust differential for this, but I will learn.
Yeah, this is awesome. I haven't thought about this problem at all. So I'm really, really excited. I feel like I should learn more from you.
Okay, so as we got the blood work and imaging done, we were more curious about what was going on with the patient. So we visited the patient and we got a detailed past history. And we got to know that the patient was treated for pulmonary tuberculosis about a year and a half ago. He was treated with empiric anti-tubercular therapy for a period of 6 months. And does that influence your way of thinking?
There's a collection of cells that can form, right? With, I think I'm just guessing at this point. Ann Marie, does that ring a bell for you?
I guess I would want to know more about, you said he was treated for tuberculosis. What were the manifestations at that point?
Well, he was treated for pulmonary tuberculosis. So he had cough and night and fever and cough.
Yeah, I mean, I guess you have to wonder about if the treatment was sufficient. Like, was he on the right therapy? Was there multi-drug resistant? Could he have been adherent to his medications? Because taking multiple medications are difficult. So, could he have had inadequate treatment? And this is now a soft tissue manifestation of that. I don't specifically know of any side effects of the medications that I would associate with that. Sharmin, do you? I can't think of anything.
For colomas come to mind, but I've never seen a skin manifestation of that. But yeah. I feel like it was I don't know if it can be even cystic, but
do anything.
That was the only thing. I was like, with tuberculosis, as you mentioned, if this is untreated TB, then the question is in someone who is 27 and relatively healthy, who's gone untreated, why, if this is related to TB, then why is he having a reactivation? Or partially treated, you have to kind of worry about resistance. The night sweats, going back to the history, that's kind of the classic night sweats, thinking about TB as well. So yeah, I don't know. I'm gonna use my favorite phrase, Achilles.
Okay, so the next aliquot that will reveal the diagnosis. So would you guys like to expand on your discussion, or do you want me to reveal that?
Ann Marie, any other thoughts?
I don't think so. I think that we have to say, knowing this history, that it seems that it could be a cutaneous manifestation of tuberculosis causing a cystic lesion, possibly associated with bony involvement or just cutaneous manifestation until proven otherwise. But I will be happy to be wrong.
Yeah, I think my next steps would be to talk to infectious disease and thinking about if this is in fact TB. You want to do the AFB smear to see if you can find any of the any of the bacilli. And then this is going to be tough because if it's TB, then it takes weeks for these things to grow, and you want to make sure that you get the susceptibilities before you treat, because if he's already gotten treated once, then you have to really worry about resistance. But I think we're just anchoring on this TB because I don't know what else it could to be. So I'm really excited to learn from you, Akhilesh.
Okay, so after that, we got a fine needle aspiration of the swelling done, which was positive for acid-fast bacilli, and features were consistent with the tuberculosis midline chest wall swelling.
My mind is blown. I knew TB can do anything, but chest wall swelling was not the thing I thought TB could do. Gosh,
Thank you so much for teaching us.
Yeah, Akhilesh, can you teach us more like what you learned afterwards about this type of TB manifestation?
Yeah, sure. I can actually share more points about the management. So the swelling after the FNA, we aspirated the swelling and it revealed frank pus, and we sent the pus for a nucleic acid test, which came for drug sensitivities, and the test came back with isoniazid resistance. So we had to manage the patient with serial aspirations of the abscess and antitubercular therapy, but without isoniazid. So we had to substitute levofloxacin. And so the complete management was rifampin, levofloxacin, ethambutol, and pyrazinamide, along with the aspiration of swellings, which we had to do like 4 or 5 times at weekly intervals.
Okay.
After a month, the swelling was subsidized, and the patient, he actually improved.
Wow. So it was like this, it was secondary infected as well. So there was like a secondary bacterial infection, or no, it was just all TB.
It was just TB. I think
just-
it was just tuberculosis presenting as a cold abscess.
Wow. I have so much learning to do today. This is fascinating. Ann Marie, any other thoughts?
I'm like the mind blown emoji right now. So those are my thoughts. Thank you so much. This was such a great learning experience, and I really appreciate you presenting. And you did such an amazing job.
Oh, thank you. It was
Yeah,
great to listen to you guys.
Yeah, I'm blown away. Thank you so much, Akhilesh. I've never seen this before or heard of it. So I'm so excited to learn more and read more. This was a wonderful, wonderful case. Mariana, thank you so much for scribing. And David, I'm gonna pass the mic to you for teaching points.
Hi everyone, thank you so much, Akhil, for the case. I was just reviewing a bit up to date in the section of cutaneous tuberculosis. This case beginning with the chief concern of chest swelling that we are not accustomed to it, and we could frame it as a localized lesion versus the chest could be diffusely swollen. In this case, the main clues to make progress were the night sweats that made us think in inflammation and the IMED pneumonic. And in this case, with the chest swelling, the cases that causes that could fit could be skin and soft tissue infections such as cellulitis or an abscess, being an abscess the most common and concerning cause. Also, there could be arthritis of the costoclavicular junction or something like that, costochondritis or stomatitis, and also atypical pathogens such as actinomycosis, nocardiosis, TB, fungi, or as Mario shared in the chat, iridosis. And well, there could be also malignancies like lymphomas, sarcoma, chondrosarcoma, or plasmacytoma in there. I like the pearl of Ann Marie of thinking inside going outside, or a process of starting outside and going inside, such as an abscess. And well, the final yes came with the biopsy or the sampling of the lesion that was coincident with cutaneous tuberculosis. I've been reading in Update now that there are two big groups of cutaneous tuberculosis: the true cutaneous TB, such as in this case, there are different direct manifestations of TB, and we can see Helicobacter in the skin. And it could be from contiguous spread, from hematogenous spread, or from inoculation from an exogenous source, or tuberculosis that are hypersensitivity reactions to TB, including the erythema indutatum of Bacin and lichen scrofulosorum, well, other kind of more weight things. So that's all, and thank you very much.
That was fantastic. Thank you so much. Thanks all, Ann Marie. Thanks again for discussing with me Kilish, wonderful case. And thanks all for joining us and for all the wonderful thoughts in the chat. We'll see you tomorrow. Bye.